So we're going to move away from all the soothing music that you were hearing earlier and talk about cardiac arrest. And apologies again, but this will be in English. Okay, so this is a topic that's very near and dear to my heart because not only am I emergency medicine trained, but I'm also an intensivist and I work in the cardiothoracic and cardiac ICUs. So I'm using echo on a daily basis. Half of the time when I'm on the surgical side, we have our post-CABG patients. Doing a TTE on them, a transthoracic echo, is very difficult because they have a massive surgical scar. They're in pain. So we're often relying on TEE. And on the other side of the double doors, where we're on the medicine side and we're seeing our post-intervention patients after a heart attack or something like that, we're using echo almost daily on our rounds to make clinical decisions. So I want to spend the next about 35 minutes convincing you all that the next time you have a cardiac arrest in your emergency department, you as the physician should grab an ultrasound and take a look. So I have no major disclosures. I'm not fellowship trained in ultrasound, but like I said, we do this almost on a daily basis. So I think I have some things to share with you. So we're going to jump into the objectives. But before I do that, this is not going to be a talk on the views that you're looking for, right? I'm going to assume that everyone here knows how to do a subxiphoid view, a parasternal long, parasternal short, and we're not going to talk about the basic things. We're going to go a little bit beyond that. So firstly, what's the scope of the problem? Why do we care about this topic? What is the utility of echo in cardiac arrest? Why do I want to convince you to grab an ultrasound? And this is going to be POCUS, right? This is not a full echocardiogram where we care about TR and MR and all those little things. What is the data support? So is this actually valid or am I just making this up? And then are there any special clinical considerations I want you to keep in mind when you're actually doing this in your practice? So we're all familiar with this kind of presentation, right? We've either already taken care or will at some point take care of a cardiac arrest in our careers. The American Heart Association tells us that every year there are about 300,000 cardiac arrests in the US. Of these, 200,000 are in hospital. Of these, only 25% survive. So only 1 out of 4 patients will survive. Not just that, only 1 out of 10 will make it to discharge of the survivors. Not only that, this statistic does not account for the patients who will be neurologically intact upon their discharge. So as you can imagine, that will be an even smaller percentage. There are multiple ways in which you can classify arrests. In my world, with my sort of training background, I personally classify them as traumatic arrests and atraumatic arrests, but you can do whatever kind of you want, right? You can have in-hospital, out-of-hospital, many different kinds of rhythms and so forth. Obviously, the situation that presents to you, so if this is a post-procedural arrest or a trauma arrest or whatever, that's going to dictate how you sort of manage them. But the ultrasound utilization should still be pretty consistent in all of those categories. So very briefly, traumatic cardiac arrests are for multiple reasons, but the 3 major categories that we're going to talk about is massive hemorrhage, right? So the tank is empty, right? The patient has bled out in the field, on your table, in the bay, and there's really just nothing left to pump around the body. If there's no blood, there's no oxygen, and you have a cardiac arrest. Blunt cardiac trauma is something we don't always see, but something that we should always be thinking about, especially in your blunt arrests that show up. This can be for various reasons, right? You can have an impact on the myocytes themselves that cause destruction, that cause cardiac stunning, that leads into a fatal arrhythmia. You can have a tamponade physiology from a bleed, a bruise, something, or you can have frank rupture. All of these things will be dependent on the force, the mechanism, and so forth. And then my personal favorite, the fact that they stood this patient up, because it says PA standing, and decided to shoot a film. But anyway, so, you have obstructive shock, right? So tension pneumothorax, tamponade as well. The majority of this talk is going to be focused on atraumatic cardiac arrest. So these are the classic two categories, which are shockable rhythms and non-shockable rhythms. So your shockable rhythms being your VFib, your VT, your pulseless VT, and your non-shockable rhythms being PEA and asystole. But if you grab your little friend, what you'll find, and if you look under the surface during your rhythm checks, what you'll find is that PEA is often subcategorized into true PEA, which is a electromechanical decoupling, right? So your monitor is telling you that there is a pulse, there is a rhythm, but when you look for a pulse, there isn't one. This is often due to electrolyte derangements, acidosis, something metabolically going on in your patient that is refractory in them, and you have to figure out. This usually presents as a wide complex PEA. And then you have pseudo PEA, where your blood pressure is so low that there's a rhythm on the monitor, there's no pulse, but is there really no pulse, or you just can't measure it? This is due to variable reasons, but your hypovolemia, your sudden RV failure, where your heart's just not able to cope with the sudden changes in the differential pressures between the left and the right side, and forward flow is hindered. This often presents as a narrow complex PEA. Now, I'll let you take pictures. But so why do we care, right? Ultimately, PEA is PEA at the end of the day, but it's not, right? So if you have true PEA, and I'm telling you that it's a metabolic derangement, then you need to do something about that, right? This is the patient you give epi to bicarb, calcium, magnesium, whatever. In your pseudo PEAs, if you're going to give them epi and bicarb and calcium, you're not achieving anything. Maybe this is the patient that needs volume. Maybe this is the patient that needs blood. Maybe this is a patient that needs an epi infusion or ECMO because they have a massive PE, and you either want to think about giving them TPA or you want to think about severe cardiogenic shock and putting them on ECPR and ECMO. So it really does change your clinical practice. But again, I could be just making this up, right? So now we're going to look at some data. So does this actually impact your clinical practice? So this was the question they asked in the field trial. This is a little dated. This is from 2010. So it was a prospective observational study at 4 centers. This is a pre-hospital study, obviously not in America, because there was a physician on the ambulance that essentially arrived on scene of either a patient in cardiac arrest or somebody in such severe shock that they were peri-arrest. And the physician that was on the ambulance did an ultrasound and tried to figure it out. So there were 230 total patients that they studied, of which 100 were in arrest, and 50% of them, 51 of those 100 patients, were in clinical PEA, but 75% were in pseudo PEA. So this was not the patient population that needed epi. This was a patient population that needed some other intervention that they were not getting until an ultrasound was placed on them. So does the presence of cardiac activity on POCUS in PEA or asystole actually impact mortality? That's the question that the Reason trial asked. This was from 2016. This was a prospective observational study at 20 different hospitals across America. And again, the only subcategory or the category of cardiac arrests that they cared about was patients in PEA or asystole who had the presence of cardiac activity on POCUS. Was there an improved survival in those patients? So they had 793 total patients that they captured. Of them, 33% had cardiac activity and 67 did not. So about a third had cardiac activity and 2/3 did not. Their primary outcome was survival to hospital admission. The patients that had cardiac activity on POCUS survived more to hospital admission. Their secondary outcome was survival to discharge. The patients that had cardiac activity on ultrasound survived more to hospital discharge. Now, if you look at the numbers, 4% with cardiac activity survived to discharge, 0.6% without cardiac activity survived to discharge. So the numbers are very, very low, right? But part of that, one of the possible explanations for that could just be we know for a fact that the higher survivability in rhythms is VT and VFib. So you're already looking at a category of cardiac arrest that has a higher mortality rate than certain other rhythms, right? So the numbers are going to be low in these studies. So this was, so then does POCUS change our practice, right? So should we be doing more of this in our emergency room? So this is a 2019 study that looked at, this was actually a retrospective review. They looked at the people who got POCUSed, did the length of their resuscitation, did the frequency of the interventions that they got, and their clinical outcomes. Was that impacted at all? As you can guess, the answer was yes. So they captured 223 total patients, 80% of whom got POCUS. Of the 80%, only about 10% had cardiac activity. Again, the numbers are low because this is PEA. The average resuscitation time in patients who had cardiac activity was 27 minutes, compared to 11 minutes in patients who didn't. So in other words, if you as a physician saw any kind of cardiac activity, you kept the resuscitation going longer than patients who didn't. 100% of the patients who had cardiac activity got intubated. The patients that did not get intubated. 95% of the patients that had cardiac activity got epinephrine, and the 5% didn't. So it was very clinically impactful what you saw on the ultrasound. One of the big criticisms for POCUS has been, it's very operator dependent. If you don't use it enough, you're not going to be facile, you're not going to be fast, and then you're wasting time. The two things that we know have had a proven mortality benefit in any cardiac arrest are CPR, good, efficient CPR, and early defibrillation for shockable rhythms, right? So if we're wasting time grabbing the ultrasound, positioning ourselves, doing all these things, are we just wasting time and impacting mortality? So that was one of the criticisms brought up in this paper. This is one of the authors is Michael Winters. This is from Maryland. So what they found, this was a 2017 prospective observational study. And their primary outcome was duration of rhythm checks when using ultrasound or not using ultrasound during a cardiac arrest. They found, so we all know that we should be less than 10 seconds. What they found was with ultrasound, it took them 21 seconds to check for a rhythm. Without ultrasound, it took them still 13 seconds, which is longer than where you need to be. But their criticism was that it takes much longer if you're reaching for an ultrasound. However, do we have to wait for a pulse check? So this is a proof of concept paper that's fresh off the press. So this is 2023, also from Maryland. And basically they said, well, hang on a second, before you throw away your ultrasound machines, do you actually have to wait for them to pause compressions to check for a pulse? So what they did is they took an ultrasound and they put them on the femoral arterial pulse during CPR. And they put pulse wave Doppler on there. And what they found was when the patient does not have any native activity, no native rhythm, you get a very clear signal. You get a very rhythmic signal because that's the chest compressions. But the patients that do start to have some return of circulation have these irregular rhythms that pop up. So you can visually see that there's something going on underneath your compressions. So is this the patient that you actually set up for an echo immediately, right? But again, this is just a proof of concept paper. This is not like this is not a randomized control trial or anything like that. So is there a more elegant solution? So we know the way to a man's heart is through his stomach, and therefore we invented TEE. So there are a couple of pros to TEE, right? It's fast, it's continuous. You don't have to stop chest compressions to get windows. There's no delay in CPR that way. And they can be used for sort of more other specialized things, like say you're putting your patient on ECMO, you're starting to do eCPR. You can not only look at the heart, but you can also look at cannula placement in real time. There are also cons to using TEE, right? If we are not even certified to use basic TTE, then how are we ever going to get certified to do TEE? It's more expensive. You have to keep up with the equipment. And then the other thing is if you've ever tried to intubate somebody that was not resuscitated, going back to my first talk, always resuscitate before you intubate, or if you've ever tried to do an EGD on someone that was vomiting in your face and really hypotensive, you can really impact their vagal tone, right? And so now you've turned a quasi-stable situation into a crashing patient. So in somebody that's peri-arrest, shoving a TEE probe down their esophagus can also make them worse. But I'm just an ER doc, right? How could I possibly do TEE? Well, it turns out you can. So this was an observational study in America in 2016 where they took 12 emergency medicine providers and they trained them for 4 hours. This is not a year-long TEE anesthesia protocol training. This is 4 hours, 2 hours of lecture-based learning, 2 hours of practical learning. And at the end, they basically followed them around in their clinical practice and saw how many times they were actually using TEE in their clinical practice. So they found that they used them about 54 scans were done, and 98% of the time, the emergency doctors were successful in placing the probe, getting appropriate images, and getting good quality images that were then interpretable. And 80% of them had a clinical impact based on what they were seeing. But we're still not convinced. So this was a observational study from Resus back in 2019. So remember how I said good CPR impacts mortality, right? So how do we even know that we're doing good CPR in cardiac arrest? We assume, we're always taught in our training that you press on the sternum and that's great. And on kind of the left side, that's kind of where your heart is and just go nuts, right? But turns out in half the population of the world, your heart does not sit behind your sternum directly. In 50% of the world, your LV compression with sternal compression is not adequate. So in this 2019 prospective cohort study, they looked at 33 cardiac arrest patients, and 50% of the time, the point of maximal compression was actually on the LVOT, so the LV outflow tract, or the aortic arch. So not only were you not compressing the heart, but you were actually preventing cardiac output. So are we as fast as we think? With TEE, can we be as fast as we want to be? So I asked the same question of TTE a couple of slides ago, and we found that it takes about 21 seconds to get a rhythm check. This was a 2019 in Annals of Emergency Medicine. This was a retrospective review of cardiac arrest. So what they did was every cardiac arrest that they had in their emergency department, they recorded it. And then they looked back to see how long it took for them to realize that there was return of spontaneous circulation on TEE. So remember, 10 seconds is what you're aiming for. It took manual pulse checks, 11 seconds. TTE took 19 seconds, so transthoracic took 19 seconds. TEE took 9 seconds. So this was the most efficient way of checking for return of spontaneous circulation, or for return of a rhythm. Okay. Oh, I didn't realize that I didn't put that. Okay, never mind. Well, that's the punchline. Get trained in TEE, people. So hopefully I've shown you some data to suggest and impact your clinical practice, but a couple of practical real life things, right? Getting an echo probe in the ED in somebody that is surrounded by 10 people who are, in line to do compressions is really difficult. So first and foremost, POCUS should never interrupt CPR, right? If you are having to push somebody away to make room for your ultrasound, you are doing it wrong. Always go subcostal or subxiphoid, because that allows you to be at the foot of the bed, or somewhere sort of lower down in the bed, so that you're not in the way of somebody that's trying to get the airway. You're also not in the way of somebody who's doing chest compressions, because the view that you're aiming for is much further down. What you want to do ideally is, before you're ready for a pulse check, you aim the probe in the appropriate position, so that when you're ready to come, when the person doing CPR comes off the chest, you're right there and you can just see if there's activity or no activity. Obviously, this is difficult in practical life, because there's gel, there's, you're now the person doing CPR, their hands are sliding off the patient's body. This happens all the time, right? The defibrillation pads that you have on don't stick because there's too much gel in the way. If any of those things are happening, stop. You're not doing your patient any favor. You're potentially helping yourself learn something, but that's not the point, right? So only do it if it's safe and you can do it in a way that doesn't interrupt CPR. One way to do that is when when you're physically on the chest with a probe, count out loud the 10 seconds, and that way you will be mindful that, okay, it's been too long, I need to come off, right? Everyone does this. I do this where I'm right there. I know if I'm on the chest for like 2 more seconds, I'll get the view that I want, but those 2 seconds really add up. And then, if you find that your patient is in pseudo-PEA and you make an intervention, but they're still in PEA, think of something else, right? So if you thought that this patient was in severe hypovolemic shock and you've given them 6 liters of volume, don't keep giving them volume, right? It's not the answer. It's not fixing the problem. At this point, you've given them the appropriate resuscitation that you thought they needed, and they haven't responded, and they're still without a pulse, which means they're probably cold, acidemic, they're metabolically deranged. So do something else. And then the punchline was get trained on TEE. And that's it. So questions? No questions. This was crystal clear. Yes, okay.
Thanks for the lecture. So just about TEE, I don't know much about it, or I even don't know the equipment. How big is it? And could it be possibly done in pre-hospital settings? Do you have any comments?
In the pre-hospital set, so the equipment that you need for TEE is, has everyone seen a TEE probe? I probably should have put a picture. So it's quite a lot of equipment. It's not, our basic ultrasounds that we carry around, right? The newer models, like the handheld ones, are just a single probe and you can like upload it to your phone. The TEE technology is not there yet, because you still have to introduce a probe into the esophagus. So you are still looking at a tower, kind of like a bronchoscope, right? So there's a tower, there's a reviewer screen on there. You have the physical probe. It's a lot more, if you guys do bronchs, if you've ever held a bronchoscope or an EGD scope, it's really heavy. There's a lot of manipulation that you have to do. If you're short like me, you kind of have to, manipulate yourself to manipulate the probe. So it's not easy. It's not, at this time, it's not really transportable. It's not portable. But they're, slowly but surely they're working on it. In the emergency department, to have a TEE probe is very possible, just like you have any other scope, right? Just like you have VL, like you have a glidoscope. It's a little bit more heavier machinery than a glidoscope, but you can leave it in the corner and you can utilize it.
I'm like you, like enthusiast, but not an expert at all. YouTube is like the source of my ultrasound knowledge. As far as I've seen, none of the studies you showed actually could show causation. That means if I do a CPR ultrasound, I save acceptable outcome for a patient. They showed like association, hypothesis, like generating studies, but I think we are like in the beginning of scraping the surface of, and I'm totally with you with the TEA. That's the most logical approach.
Yeah.
So what I usually say in CPR, the worst thing that can happen in a CPR situation, that the cardiologist comes down with his ultrasound probe holding high, and that just disrupts. So is there any numbers on that you actually save acceptable clinical, as a patient to accept the clinical outcomes by doing ultrasound in CPR situations?
So the clinical impact is in the patients it's in the intervention that you make. As we kind of already discussed, right? You're looking at the worst possible group of cardiac arrest. So the numbers in PEA and asystole are already are already terrible. Of those, if you have somebody that you are not giving the right intervention to because you think that they're in PEA, but they're not actually in true PEA, they're in some other form of shock that's presenting like fake PEA, those patients are the ones that you make an interventional impact on. But that is a very sub category of patients. And on my first slide, right, the mortality in this is 75%, right? Of the 75% of patients who are going to die of cardiac arrest, you're looking at a very small percentage. So it's really hard to say that you will save 0.1% more if you do a POCUS versus, not saving them. So I don't have the mortality numbers for you because they're really hard to prove. The studies that have looked at mortality itself will quote numbers like 2 or 3%, 5%, but they're they're very small, and I don't think that I can reasonably extrapolate that to everyone.
Still, they are mostly either retrospect,
correct,
or just observation.
Correct. Right. There's no RCT on cardiac arrest. Correct.
So there is like observational retrospect studies, so which gives us the idea of we should do a study like one day we use ultrasound, one day we don't, and we do it for a year multi-center.
Yeah.
And then we change our recommendation for CPR because I think over a population of doctors and patients, it's probably right now in our setting, if it's not the esophageal probe you use, you make more, you will do more harm than good. There might be some like well-trained high volume EDs that are like really training on this. ultrasound during CPR, then there might be no harm to the patient. But I think if you if you take it too easy and too fast implement ultrasound in like common practice, there's quite a risk that like if we go home now and say, let's do, then that probably the risk of doing more damage by low quality CPR is higher than that. That's at least my observational study.
Yeah.
I stopped doing it actually in the pre-hospital setting. I don't do it anymore. What I do is the probe to the femoral artery. I think there's no risk in interrupting anything, but putting something near the chest is like high risk, in my opinion.
Yeah.
And there's no proof that it helps.
So in my clinical practice, I would say that I 100% cardiac arrests I do an echo on. But that's because I do it every day.
Yeah, exactly. That's the difference. I think you work in a cardiac environment where you see probably CPR a couple of times a week.
Yeah.
Which is not common for emergency physicians in like normal setting. So and you probably are highly trained with your team that anybody knows, okay, I have to count to 10.
Yeah, exactly. So, which is why, at the end, the first thing I said is if it's getting in the way of CPR, stop, right? Most of these studies are done in the US, in Australia, in New Zealand, in places that have very well-established pre-hospital groups, right? They have a very centralized EMS system. There are also people who are very forward-thinking in POCUS. So like, I think it's MCRIT and Life in the Fast Lane, which are all websites that you should be using. These are all out of Australia and New Zealand. So there's a lot of interest. There's a lot of people who actually do this on a daily basis. So I think you're right. The one sub category of the pseudo PEA that I do want to just talk about is the VT patients or the VFib patients who you have no pulse, but when you put the probe on, your heart's actually fibrillating. Now, that is a very small group. I don't have a number to tell you that, X% of your pseudo PEAs will be your slow VFib patients. But there is a category of those, and if you then defibrillate them, that does make an impact.
For me, this is like a non-question because I will never ever delay compressions where I work in Uppsala because the nurses will just keep on compressing. When time's up, they start, even if I'm on the chest. And I'm not in the way. I'm like leaning in like this. So I don't see how I could delay compressions because they will just continue.
Right. So, the sort of protocolized approach to resuscitation is very well established in trauma, right? Where you have positions that people stand in, right? There's the airway person at the front of the bed. There's a primary survey that's on the left. There's a secondary survey on the right. And then there's somebody doing an ultrasound. If that sounds very unfamiliar, that's at least how it's supposed to be in my neck of the woods. There is no such protocolization for the use of POCUS yet, right? But maybe there should be. So if you have a box on the floor where this is the box that the person doing CPR stands in, and there's a box on the other side where this is the box that the person doing POCUS stands in, you then have a safe space that you've not violated your or anybody else's positioning based on where you stand. It is impacted a little bit by, the type of ultrasound machine you're using. If you have like the really old sort of Stone Age models that just take up a lot more room, and then you have to plug them in and stuff like that. So if you take nothing away from this talk, it should be POCUS should not get in the way of CPR. If it is, then stop.
Yeah, about this focus check during pulse check and rhythm check is that I normally just record a video for 5 seconds and then I step aside.
Sorry, are you done?
Yeah, it's just a tip.
I get really excited about that. So yes, that is actually a validated way of doing a rhythm check with ultrasound. So it's the duration of your clip, and that way you have a time check, right? So perfect. That is a very well-established way to do it. Anything else? Okay, thank you.